Okay, we'll get started. So, good afternoon and welcome to our Northamptonshire Health and Care Partnership Race Equality event today. My name is Anne Linsdell and I'm delighted that you can all join us. We're here today to say the session's called Why Are We Still Talking About Race? And I know it's going to be a really informative and engaging session. So I'm supported today by my colleagues Diana and Louise, and we will help facilitate this session. There are a few little bits of housekeeping. At the moment, your cameras and your microphones are turned off. This will not affect your sound coming out of your computer. It's just so that we get a better experience for colleagues that will be watching on demand and obviously can't be released or can't attend directly today. There will be an opportunity, hopefully, for questions at the end. There are two ways to do that. You can either put your questions in the chat box, or you can use the raise your hand function. And if you use the raise your hand function at the appropriate point, we will turn your cameras and your mics on. So please don't worry about that. As I've said, we are recording this session today so that for colleagues that can't attend live. And if you are hard of hearing, there is the opportunity for you to turn on live captions within Teams on your own computer so that you can have the live text running under the session plan. We are going to, today we are joined by Toby Sanders and Angela Hillery. During today's session, we will go into breakout rooms to have a bit of a discussion about actions that we can take. So when we get to those, I will explain how that will run, but you don't need to do anything. The magic of Teams, hopefully, will do everything for us. So without further ado, I'd like to hand over to Toby.
Thank you, Anne, and good afternoon, everyone. My name's Toby Sanders. I'm the Chief Executive of Northamptonshire Clinical Commissioning Group, but I'm also looking forward to the designate Chief Executive for the Integrated Care Board for our Northamptonshire Health and Care System going forwards, and currently the NHCP Executive Lead. And I'm delighted, really delighted to be able to be with you all this afternoon in terms of opening today's session and introducing someone in a few moments who needs absolutely no introduction, I'm sure, to all of you, but to Angela before she gives our key speech. But before doing so, I just wanted to share a few personal reflections really for me about why, when I spoke with Diana and with Anne and was asked to open this session, I was so pleased to have the opportunity to do so. And I wanted to just begin by sharing a little bit of a personal kind of journey and reflection really on my perspective in terms of kind of race, ethnicity and the importance of this agenda. And it's still of the importance of this agenda to us today, particularly from a health and care perspective. And I want to start my story really by just going all the way back to where I grew up in Cornwall. I grew up in a very predominantly white, very rural and predominantly agricultural community in Cornwall. And I went from there to Manchester to university. And it was the first real time that I'd left that kind of very, very undiverse, frankly, and kind of upbringing in that kind of part of the country at that time. And moving to Manchester to study and live in a really, really diverse city, massively kind of multicultural. And even my very first experiences of moving into halls of residence and sharing rooms with a Sikh chap who was training to be an engineer, with a Chinese guy with us who was training to be an architect, and a number of others who come together from all different parts of the country. And I remember the really deep, profound impact that had on me personally at that time in terms of kind of my view and perspective on the kind of breadth of different interests and backgrounds across society. And over the years, the experience I've worked in different areas have really kind of built on and kind of added to that kind of perspective. I started off out of university working in Salford in Greater Manchester, working alongside the Jewish community in a community development role, helping them secure really small scale funding for community development and capacity building programs and projects. Later on in my career, I worked, before I joined the NHS, in South Yorkshire and around Sheffield, working in particular alongside Black and Black Afro-Caribbean communities, working with an Objective 1 programme that was supporting people back into education and employment and focused on skills and training. And in the 10 years or so before I came to Northamptonshire, I was working for the NHS in the Leicestershire area, in part of Angela's current patch these days. And they're working very closely alongside general practice and health and care services within such a diverse community, particularly alongside the Asian communities within Leicester. And since then, the 3 years I've spent here and been my privilege to lead and work alongside many of you in Northamptonshire over the last 3 years, of course, we've been through 2 years in particular of really unprecedented circumstances in terms of COVID, the pandemic, its impact on our population, their health, and its impact on our workforce and our staff base as well. And I think coming out of all of that set of combined experiences over the years, there's kind of 3 big things that stick with me in terms of coming into today's session. And it's about the inequalities in terms of racial and ethnic disparities that so many of our population and our staff groups face and experience on a day-to-day basis in really 3 broad areas. Firstly, there's been so much national and international research and evidence on this, particularly over the last couple of years through COVID, in terms of the impact of racial and ethnic inequalities in terms of access, experience and outcomes for healthcare. And the data on it just speaks for itself. So a conversation today about why we're still talking about race. Well, we're still talking about it because it matters, and it matters more than ever today in terms of where we are in terms of those disparities in terms of health, access, experience and outcomes. But it also really matters for me, of course, personally, in terms of our workplace and our workforce, and in terms of the unequal opportunities, different levels of representation, and also the experience of our staff in the workplace, whether that's from colleagues, whether that's patients, whether that's from members of the public as well. And thirdly, and really importantly, and I think this speaks very much to the opportunities looking forward that I'm excited about in Northamptonshire around the integration agenda and working together with health and local government in terms of the social economic circumstances and how those factors impact in terms of those wider determinants around education, around employment, around poverty, on the life chances and opportunities for our population and for our staff. And so when I was asked today, if I minded saying a few words up front and introducing Angela at the start of today's session, I was delighted because this is an agenda that I'm really passionate about. I don't think there's ever been a time within the NHS in my career that this agenda has been more front and centre stage, and absolutely rightly so, coming as we are, thankfully, through the kind of out of the stages of the COVID pandemic. And I'm looking forward to the opportunity to working with Angela and many of you on this call as we take the agenda forward through the Northamptonshire Health and Care Partnership and the similar forums across the East Midlands, working together to do things differently and to make a real difference to opportunities, outcomes, life chances and employment experiences for our staff and for our population. So without further ado, I did say to Angela I wouldn't say too much up front, that I probably already said a few more words than I intended to, but I think I can recover a little bit here because I've certainly no intention of spending too much time introducing Angela, who I know will be known to almost all of you, I'm sure, on today's call, but it is genuinely a privilege and an honour to be able to introduce someone who actually was a key part in attracting me to come and work in Northamptonshire. When I looked at the people that were in the county a few years ago, and I could see there were great leaders here like Angela with such a strong passion and commitment and such a values-based approach to healthcare, I wanted to come and be part of the team that was working across the county. So without further ado, Angela, I shall bring you in and hand over. Thank you.
Thank you, Toby, and thank you for sort of setting the scene and giving us that real sort of sense of commitment from yourself. It's really welcome. And if I can just say thank you as well to everybody who's joined this afternoon, because that really is inspiring in itself, actually, that people want to listen, take part and participate. I think that gives us all energy. So thank you for that. I hope people did get a chance to listen to Yvonne Coghill earlier in our session, our previous session. And if you didn't, I would just urge everybody to still access that. We've recorded the session, and I think if you haven't seen it, please do. And if colleagues that you work with haven't, please encourage them to as well. It was truly inspiring as ever from her. So why am I here? Well, I'm certainly not here because I'm an expert, because I'm not. It is not expertise that I'm here to share with you this afternoon. It's really I'm here because I believe that it is important that we all influence health and care systems to discuss race and racism, and that's why I'm here. I lead 2 organisations, as Toby suggested, across 2 ICSs. And what I would just say to you before we get into the session more fully is that I'm very clear I have white privilege and I am an ally. And I wanted to just share with you what that means to me in terms of being an ally. It is not about being nice to people and just saying what you think others want to hear. It is about being open to discomfort and challenge. It's about making mistakes and learning and putting yourself into that situation. It's about asking questions and being curious. It's putting ideas into what you do every day. And it's also about challenging the status quo. So I'm very clear that's why I'm here today. So why is it important to still be talking about race? Well, as Toby said it, and I quite agree, it is because it is still a key priority for us in healthcare and all our organisations. And we have to act together to do something about it, and we have much more to do. So over the next series of slides, I just wanted to stimulate some thoughts in terms of why I think these are areas that we could and should be thinking about more collectively. And what I'd like you to do is to think about them from an action point of view, because our strapline is very much actions, not words. So as you're listening to some of the thoughts, think about it from yourself as an individual, from your organisation, and also from the system in which you're working as well, because action at every level will be required. As Anne said, we're going to move into some breakout groups because we want you to co-produce and start the movement with us in developing EDI strategies that we can all celebrate and take forward together. Next slide, please. Now, I've started with a quote and I'll just read it out to you all. While the use of the term racism is more ubiquitous than ever, many official bodies and people shrink from the concept of race. Our understandings of racism are increasingly divorced from historical understandings of race and racial difference. An avoidance of race undermines our ability to engage in clear and meaningful measures of difference, as well as our ability to challenge racisms. So it's a quote of many. So why did I pick that quote? Well, the reason that one struck me as important to share today was because it is more widespread that we're talking about racism. There's certainly more being said nationally, locally, regionally. But we can also be lulled into a false sense of security that because we're talking about it more, action is being taken. It doesn't mean the same thing. And it can also mean avoidance needs to be examined too, because in my experience, people do avoid talking about it. And that's something we've all got to understand how we can make a difference to get people more comfortable with it. Because if not, it becomes a troublesome concept. It becomes something that people think they need to avoid and not go near. And of course, what I'm saying is that we need a continual dialogue and we need learning spaces that we can have that dialogue, that people feel safe to discuss it. So again, I would ask you to think about, is that being avoided where you are? Is learning happening where you are? Is it being avoided? And what is happening to make that a reality for you? Now, of course, talking and learning won't eliminate the issue, but it does give us the chance to get to the heart of what we can do differently together. Next slide, please. Now, Yvonne spoke a lot about health inequalities and Toby's mentioned them too. And of course, I couldn't talk about my session without referring to them as well. And we know, as Yvonne told us, that disparities are widening, and that is clearly very important to us. So this slide reminds us of that. But what I really wanted to draw your attention to is the words underneath, and the one that really strikes me is preventable. And I want you to hold that thought and think about that in relation to action for our systems, our organisations, and for our people. Because we can often get drawn to the fact that we think these things are not solvable, but it is clear health inequalities are preventable. Next slide, please. Now, we also know, and these are facts, that we have ethnic health inequalities in our country. And just to give you a flavour of some of those, they're illustrated on the slide, but just to draw some of those out, we've got more people in the Black African and Black Caribbean people 8 times more likely to be subjected to community treatment orders than white people. We've got South Asian and Black people 2 to 4 times more likely to develop type 2 diabetes. And Black women are 4 times more likely than white women in the UK to die in pregnancy or childbirth. And there's more. And we know these facts. So what is it we're going to do? Are we going to comment on them? Are we going to just look at the facts? Are we going to do something about it? And of course, the real challenge for us is, what does that mean for us locally? What does that mean for our population? Because as Toby has said, our populations are different. So it is incumbent upon all of us to understand what that means for us, our services and our populations. And that's why it's so important that we are talking about race in relation to the service provision, the healthcare that we're providing, because these statistics will exist in our local systems as well as in the national data set. I was also party this week to some discussions about the resources that are going towards health inequalities, and I will just share some of that with you, because again, it's probably something that we don't routinely examine together. But what I heard was that 15% of primary care resources, 10% of ICS level resources, and probably about 5% of specialist service resources are targeted at health inequalities. So my question is this: where is that being spent in our local systems? Is it making the difference? And is it impacting upon some of those statistics that would make a difference for our population? So remember the word as we go through: preventable. Next slide, please. Now, this again gives you examples of the impact on health and the fact that we can make a difference. And I'm not going to read those out, but I am, we're happy to share the slides. And I think it's really important that we collectively understand there is an impact. So if we're not taking action, this is something that we can look at collectively in our ICSs as new opportunities. Next slide, please. Now, Toby's mentioned COVID, and this is so important because, again, we know that the disproportionate effects have been significant, and we know that people have had more death rates in terms of our ethnic populations, and we know that people have had more COVID than in other ethnic groups. So what are we going to do about that? Are we going to look at our stats in our local systems? Are we going to say, actually, yes, there is more? But what is that telling us, and what are we doing about it? And are we collecting even the right data to understand who needs to still access our services? Because again, I think the other point I would make is about the data collection itself. So are we confident that the data is giving us the true picture of what we need? So we talk a lot about waiting lists, we talk a lot about people in services, but who are those people not accessing services? Do we know? Do we care? Do we understand how we can reach out to them? If we look at our vaccination levels in Northamptonshire, we know that our lowest level uptake was in white other category. What does that mean? What category is that? To understand our population more, we would need to examine that and ask some different questions. So COVID in itself has given us a platform through which we need to challenge ourselves even further. Next slide, please. Now, this is an example of something that happened within NHFT, and I wanted to use this as an example to illustrate several things. It could have been in any organisation, but I just wanted to share with you several things. It touches on data, it touches on health inequality, and it touches on leadership and resource and action. So hopefully it gives you a sense of how we can do things differently. But in NHFT, and you'll see that the slide refers to something way back in 2011. And this was a time when we were approached to be part of a project. It was called reverse commissioning at the time. And we were asked whether we were prepared to basically hand our data over to another party and to have it examined and to have a look at it in relation to Black and minority ethnic populations. And what I would share with you is that not many trusts who were approached in the country wanted to do that. And we said, yes, let's do it. Felt a bit scary at the time, but we did embark upon that. And what that told us quite clearly was that in seclusion, okay, so those in mental health services will know that we have to seclude people. that the proportion of Black and minority ethnic service users was higher than expected. But we didn't know that before we looked at the data. The detention under the Mental Health Act, the proportion of Black and minority ethnic service users detained was higher. And we didn't know that either because we hadn't looked at that data set. The referral to services was higher than expected for a number of agencies, including the police, the courts, criminal justice service. And community treatment orders, which I mentioned before, were higher than expected. Yet our access to things like psychological therapies were lower. And actually, our personal health budgets and the work we'd done on that were mainly going to white British patients. So a lot of questions, a lot of thoughts, but if we hadn't had that data set being looked at in a different way, we wouldn't have known. And that's my point about actually, are we looking at the right information? So over a period of time, we put resources into this project, and I'm pleased to say that Diana was involved in that. Gordon King, who's been involved in NHFT and LPT and since retired, was also instrumental in this. And we continued to work on the data and with our communities. It really was an opportunity to work with them. And I can remember talking to community champions who absolutely said, Angela, we don't even have terminology in our culture for what you're describing. And we didn't know that. But we trained and looked at that together. And we obviously looked at where we could provide targeted input in the areas that we've described. And it still goes on. And you'll see in terms of in 2018 and onwards, we developed particular targeted areas of support based on this data, based on the engagement with our service users and our communities. And we introduced things like body cameras, which again helped people feel safe in terms of when they were under restraint or seclusion. We did increasing audits, we had police involvement, we had a real partnership around how we can make a difference. And I'm really pleased to say that's led now to a real firm joint action plan around working with our community champions, doing engagement around health inequalities and how we can work together. But the reason I illustrate this is because it demonstrates this journey is not a quick fix. This is something over a period of time. Perseverance is needed, resources are needed, leadership is needed, because many leaders were involved in this, and you can't do it on your own. So involving community champions is really important in that space too, and challenge yourself about the data set that you're examining as well. We could have chose to ignore the data when we got it. We could have said, actually, that's a project that we're going to meet, really helpful, we'll move on. We didn't, and we're still on it. So really, really important illustration. Next slide, please. Now, of course, the other aspect that I wanted to introduce today was not just race and health inequality, but also racism. And, what's really important and important that I say as a senior leader in the NHS is that racism exists in the NHS. It's certainly in my organisations, and people can be uncomfortable saying that. I'm not uncomfortable saying that because I know it. But what is important is that we need to understand our staff. Our staff are our biggest asset in our organisations, and their effects, their experiences impact directly not only on them, but also healthcare, because we know the evidence tells us that people, how they experience care is directly affected by those staff and those experiences. And what you'll see in front of you is some recent survey from the British Medical Association, which clearly indicates that racism is very clear and apparent in our doctor community. So again, we have other data sources, we have our staff surveys, we have our res data in our local organisations. Where are we talking about that at ICS? Where are we going to talk about that at ICS level? Are we going to just note it, or are we going to act on it is a question? And I think it's something that, again, we all need to recognise is affecting healthcare and people's experience of working in the NHS right now. Next slide, please. We also know, because again, this is data and evidence that we have, that freedom to speak up guardians in the NHS exist. That's a fact. But we also recognise that people from a Black and minority ethnic group are less likely to speak up around safety concerns or concerns that they see in their organisations to white staff members. And predominantly Freedom to Speak Up Guardians are white. So again, we have a choice to make here. Do we tick a box to say we've got a Freedom to Speak Up Guardian, or do we take action to increase the number of champions across organisations with characteristics, Black and minority ethnic characteristics, protected characteristics, to really signal value to our staff to say we recognise this, we want to do something different. We've certainly taken those steps, and we saw massive increases in terms of people speaking up because of it. I love to get more and more speaking up, because that tells me people feel that they want to promote the safety in our organisation, but taking that action was really, really important. So really have a think about how people are recognising these stats and what we're doing with them. You can be tokenistic about it, and I've certainly inspected trusts and felt that to be the case. So let's make sure that that's not the case in our local systems. Next slide, please. Now, the other important theme for me today in terms of why we're still talking about race is because of the role of leadership. Now, clearly, Toby's spoken about that, and he will play a pivotal role in setting the context in which we develop a culture in Northamptonshire, and all the ICS CEOs will be doing that. But the reason that I've put this is because we're all leaders in our local areas, and I didn't want anybody to think that it's only certain people that can make a difference. It really is incumbent upon all of us to do that. But I just wanted to share with you some of the steps we're taking in our organisations to signal the intent and to take action. So we are working across NHFT and LPT, and we do that around a range of priorities that we think are important and we could really work on together and make a difference on. And one of them is called Together Against Racism. And that is a deliberate intent and signal that we recognise we have racism in our organisation, amongst colleagues, but also from patients and those that come into our services. So we've said this is a significant priority. So we are resourcing that, and it is something that I lead across the organisations. And just to give you a flavour of some of the things that we've done as a result of that so far, we've got a lot more to do, don't get me wrong, but we have looked at masterclasses, we've brought people in to speak, we've thought about psychological safety and what that really means. We've had discussions about inclusive language. We've made pledges. We've looked at developing the knowledge and understanding of racism in our organisations. And we have so much more to do. But this is the important point, is that you have to start a journey and you have to keep on it. And it's not enough to do a 6-month project or 12 months. It has to be part of your OD and your culture as an organisation. Now, as part of that, of course, what I've also said is it's really important that we all take steps as leaders, and that's something I feel very, very strongly about. So next slide, please. Now, 2 things that I just wanted to illustrate here. The first is an example from a trust where they took a very small step, which I'm sure would have been down to an individual or a team saying, actually, we're going to make a difference. And I just wanted to use it as an example of small steps can make the difference too. So this was just the use of plasters in their emergency department, because what they'd done routinely was use skin-coloured plasters. And they recognised that that wasn't meeting the diversity of all of their population. And the fact they recognised that and took action to then introduce the cartoon-based plasters, which meant everybody felt the same, included, and we didn't have the skin-coloured effect. It's just a simple example of the difference we could all make in all of our services every day. And are we thinking like that? Because those small changes really do matter. And then I've also introduced a quote you'll see at the bottom from Mayor Angela. Now, the reason I've introduced that is, one, she's an inspiring leader of mine, but important are her words, because she says, our young must be taught that racial peculiarities do exist, but beneath the skin, beyond the differing features and into the true heart of being, fundamentally, we are alike, my friend, than we are unalike. Those are really important words because it brings the notion of children, young people also into the task that we have in front of us, which I know people would get, but it's just an important way to just reinforce that. But the other reason that I brought a quote in, as somebody who inspires me, was to also signal to us as a group that the words that we're saying are also impacting on our colleagues and the people that we work with. So they will be looking at what you're saying, what impact you're talking about in terms of race and racism, and your words will be making a difference, much as mayors are making a difference for me. So never underestimate your role as a leader in any part of the organisation and the fact that you are making a difference for people just by what you're saying to them as well. So without further ado, as I say, I've given some thoughts and hopefully stimulated some discussions. I'm going to hand over to Anne now to give us some chance to reflect a little bit on that in our groups, but also really to start to think about the actions, because I said earlier, I want us to get back into what are we going to do individually, organisationally, and what are our expectations of a system going forward. So we're going to break into our groups and then we'll come back together. But over to you, Anne. Thank you.
Thank you, Angela. And I just wanted to say there's lots of love and appreciation in the chat. People loved your description of being an ally. Refreshing to hear local data. Realising that often leaders that not necessarily at the top but can struggle to talk about racism and inequalities, and how important the little things are that can actually make a difference. So yeah, there's a couple of questions in there, but what we're going to do now, as Angela says, we're going to move into breakout rooms. You won't need to do anything. My colleague Louise has been working behind the scenes to put you all into randomly allocated breakout rooms. We're going to be in breakout rooms for 10 minutes. And it's an opportunity to discuss together in smaller groups, reflecting on what you've heard and your thoughts about what you've heard, and then thinking about what actions you may want to take as a direct result, because this is very much about actions, not just words. So we'll put you into the breakout rooms. We will, when we come back, we will ask, we've got a lot of people on the call, so we won't be able to hear from every breakout room, but we will ask colleagues just to share some thoughts or just some of the themes of what was discussed in their rooms. I'm going to ask a few colleagues to share some thoughts of following the discussions that you had in the room. If you could use the raise your hand function, that will allow us to pull you in. So if I can ask some colleagues that want to share a few bits of what they discussed in their room to come onto screen. So Diana, first, quick, speedy off the mark.
Right, so just to share with you what we discussed, I think what was quite impressive was the data collection, and also using that data for quality improvement purposes to improve the experiences of our patients and clients that use our services. And also that data will act as evidence for further actions. This is the reason why we're doing it, because this is what the data is telling us. And secondly, what we did discuss, which was a real powerful point, that data can be used to move the dial. And I know Jags talked about that in the chat earlier, but it's so important to understand and appreciate the power that data can have. Used in the right way, it can help us to combat racism in our organisations. Thank you.
Anna. So if I can ask some other colleagues, we've got a flurry of raised hands, which is brilliant. I'm just trying to see. Zakaya, I hope I've pronounced that right.
Zakia, hiya.
Sorry, thank you.
That's all right. Sorry, my camera's not working. I'm the one who forgot to do updates this morning. Yeah, we talked about quite a range of experiences and really commented how good it was to see some of these slides that you presented on earlier, Hillary. I think for me, it was really refreshing to have you know, a white person leading a race equality discussion, or you know, at the most senior level. So for me, that's been quite positive in that sense. We were talking about how, there's subtle racism goes on, even if you're in a senior management position, around how resources are distributed, in terms of how you are spoken to in a leadership setting. Often people dismiss what you say, so it definitely goes on in you know, the world of social care and health, and a lot of times senior managers don't understand that or know how to deal with that, and particularly in a majority of you know, if majority of the room is white, I would say 99.9% in social care where I am, it is white, so it becomes very difficult to be the only person standing up and trying to talk about race and how you're treated differently. So I think that's an uncomfortable experience as well, having to talk about it. And Andre was saying, you know, earlier as well in our group, that it can be traumatic for BME people to talk about their experience of racism. Another thing I've noticed is when you do talk about racism, there, in where I am, LGBT becomes the topic that everyone's more comfortable talking about rather than race. Race seems to be sometimes very difficult to talk about and understand, even though we know the data's out there. And the last thing I'll say is we also spoke about making sure people had educational opportunities, because they may have not received those at school, and the statistics do show us that. You know, I was listening to the podcast on the Trojan scandal in Birmingham, and the school that you know, was involved in that had 4% achievement for Pakistani children, and you know, with the right leadership it had 70%. But then all that controversy happened about Islamophobia kind of material, and it's dropped back down to 40%. So it just shows you that it can't just be around talking about it. It's about offering career opportunities to people and how we break down those barriers around having you know, degrees or particular clinical qualifications to do stuff. For people from BME backgrounds, to enable them to have more opportunities, maybe as they come into our systems and organisations, rather than from, you know, rather than not accepting those qualifications. So we do need to break down some of those career pathway barriers too, so people can actually, you know, that's the action, I think. So that's something I'm doing in adult social care. Sorry if that didn't come out so as I intended. That's the other thing, when English is not your first language, you also end up not being seen as articulate, or you know, not able to understand what's being said. And I'm, believe it or not, an assistant director who knows my craft well. I'm a social worker by background, and a lot of the time some people will use, you know, like words I'm not used to that are complex, so I have to go and look them up or Google them, which you know, which if they used what it means, the actual definition, I would easily understand the word. But those are the kind of barriers that we face as BME, particularly you know, women like me are from Pakistani background. It's very difficult. Just in case the name throws you, I'm from a Pakistani background, but my husband is English. So we're in a multicultural relationship. And I was also explaining that in your personal life that can have barriers and other experiences, such as prejudice from a Pakistani community because you're with a white male partner, and also prejudice from John's you know, community too, because he's with an Asian female. And then we have a mixed race child who's got blue eyes and is really pale, so people often think I adopted him when actually I gave birth to him. So it's actually everywhere you look and turn. So sorry about hogging the floor.
No, please don't apologise. And there's a lot of, if you look in the chat, there's a lot of respect and for the points that you've made in the chat and that you made so well. So thank you for that. Next, I'm just conscious of time, so we've got the question next. Samuel.
Yeah, in our breakout room, we I think we talked about more about why is it difficult about talking about these things, because these are difficult conversations to actually sit down and talk. And I said, even for a white person to start saying, okay, this should be stopped, this should be stopped, that white person is putting themselves into danger, because it's like you're going to create enemies because of the white privilege concept, which has been there for donkey centuries. And the mindset of this white privilege that is embedded within the people makes it very difficult to break that sort of taboo of saying we need to talk about this and we need to address it. It's not like nothing has been done. A lot of policies have been crafted, beautiful, but then are they actually being effective? Who is taking it ahead? So even when you are working as part of the team, say you go to senior management, for example, even the colleagues you are working with, they look down on you. They don't even want to take orders from you. And you take it to senior management and say, oh, take it down to this person. So you just go back and forth, back and forth. But then again, like the data said, I mean, ethnic minorities or people of color are more likely to be done by this, by this, by that, as compared to their white counterparts. That is the white privilege concept in operation here. So then what happens? If you do something as a Black person, then they will bring the policies, make it much, much clearer to you and being applied onto you, as compared to if there was a white person, they make it blurry because you don't know much about this policy. And that's it, done and dusted. So that's what's going on. So the whole thing is, as you also hear in Parliament, the same problems in the police force, everywhere. It's just the white privilege concept in operation everywhere you see in the industries, everywhere. So it's, yeah, we can carry on, it's work in progress, but it's really difficult, to be honest.
You're on mute, Anne.
First time today. Thank you for sharing that, Samuel, and again, lots of love in the chat for you. So I think we've got time for one more bit of feedback, and I think Carol, you've got your hand up.
Thank you, Angela. That was a lovely presentation, and I think for me and the people in the group, it is really something great seeing somebody coming forward in a decision-making leadership role and saying this is happening. But that's not enough. Sorry, Angela. My challenge to you is we'll start, for example, the training that's coming out nationally for NHS staff. It's coming. We don't know who has made decisions on that in regards to that aspect. So training is being decided that it needs, but no one is set down to understand that most people who come from BAME backgrounds, they already are very academic. What is it that they are missing? Because they're being told you're not leadership material, or you're not management material. What's missing? When you sit down with each and every one of them who already managers, they'll tell you what they lacked. And then you call the ones who are pursuing to be management and you share the stories you've had, you'll see that the skill set that are being implemented at the moment, it's like a tick box, and it's going to cause a ripple impact within the NHS and cause other psychological impact, because people will be frustrated because there'll be no way to progress them to, and they will still not have the skill set or etiquettes that are required to be in management roles. So for me, as a white ally that you are, and as you sit on tables that many of us do not sit on, I think if change is about to happen, change has to ask what are the actual etiquettes that are missing, that is holding or a barrier for BAME staff into management, not the academic, the amazing. It is about the etiquettes, the way they express, is it the way they express themselves, what's influencing them in regards, and then that's incorporated in decisions that are making, because managers at the moment have the power to say no and discriminate against someone in a recruitment process. And that is because they don't know what other alternative is available, because a culture is a way of life. The culture, institutional culture, is amplifying that it is acceptable, and it has to change and start from somewhere. And we need you to help us change that. Thank you.
Thank you, Carol. Angela, did you want to come?
I mean, yeah, I know we're conscious of time, but I just want to say thank you to everybody for participating and giving some thoughts into that session. I've been brave enough to say in a group as well, but you're absolutely right. And I think Carol summed it up in terms of the word culture. We've got to, this is not a action plan. This has to be a culture that we're trying to work on together. And that's in organisations, it's in teams, it's in our system, and it has to be that collective action. So I think all the things that have been mentioned are about that piece. And I think with Toby here today as well, I think that is something Toby will have heard in terms of what his commitment is to, in terms of, as well as mine, in terms of making this a culture of our systems, and hopefully people can take that into other systems and come from other systems as well. Now we've got just a couple of final slides, and if we can share, please, just to finish off with. Now, this is a visual that I just wanted to leave people with, because I think it just sums up really what we need to think about in terms of taking action ourselves. And you know, as it says, you know, a bridge and a wall are made with the same material, but a bridge joins people and a wall divides them. We have to ask ourselves, are we being a bridge or are we being a wall? And that goes for, are we being a bridge for our populations in terms of the data we're looking at, the access? Are we acting as bridges with our colleagues? Are we looking at the racism, or are we putting walls there? So it's just a good visual, I think, that helps us to think about actually what are we doing as individuals and what are organisations doing as part of that piece as well. And then I've also put a link to some hopefully helpful tips around actually talking about race and having meaningful conversations, because I know that's something people can find uncomfortable. There's some tips there that I think I found helpful, and I'm sure others would the same as well. So thank you. And then the final slide is just to say that we don't want to stop here. Hopefully you've got that from the session. This is a journey for sure. And Diana is working in Northamptonshire on the system, but obviously works across other systems as well, because, you know, people reach beyond their own local system, and certainly Diana's one of those. But certainly in Northamptonshire, we want people to get involved and to make sure that we hear what you were talking about in your groups. So please link up with Diana. We want to make sure that we do develop and co-produce our own EDI strategy for our system. And I'm hoping for those that have come from other systems, if you have, that equally you are thinking now about actions you want from your local leaders to create the same culture effect that we've described here today. And finally, thank you very much for joining and having the discussion. It's given me energy to know that people want to make the difference. I know there's a lot of challenge to me personally in doing that. I hear it. And all I would say to people is don't get into asking people to share their lived experience if you're not prepared to take action. Thank you.
Thank you, Angela. Toby.
Yeah, thank you, Anne. And I'll be super brief because I'm really conscious that we're a few minutes over and people will be heading off to busy afternoons. There's three messages from me, really. Firstly, I just wanted to add my virtual clap and applause to Angela for everything that she said in leading the session. Angela, as always, as I said at the start, a really inspired, values-based presentation and conversation. So thank you so much for leading and opening up the conversations. Secondly, as if not more important, I wanted to say thank you to all of you for taking the time today to engage in the conversation. I really wish we could have spent another hour actually listening to people. There's been stuff flying in the chat function in the last 10 minutes, and I've been trying to keep pace reading it because there's some really rich stuff in there from the conversations people were having. So I guess it's a comment really to Diana and to Anne. We need to find a way to carry this conversation on and to be able to kind of channel the thoughts and ideas that are coming out from all of this. But a massive thank you from me to those of you, particularly who've been really open in sharing some of your experiences, which have been really impactful. The third and final thing I wanted to say, and this is just kind of looping back very personally to this, and Angela touched on this at the start of her presentation, I am well aware that I've had and have a very privileged life, and I've had access to opportunities over my life that many other people across the country just have barriers and obstacles put in their way. And I get that. I know that is my experience. What it does do, though, is I am in a position, in terms of a position of power, in terms of position of resource, in terms of position of leadership. And like Angela, I'm someone that wants to do something positive with that, to be able to address some of those issues we've been talking about today. I think that starts, though, with being comfortable in acknowledging that that is where we are and where we come from into this conversation, but that we are individually and collectively, through the partnership and through our integrated care system going forwards, we've got some brilliant opportunities to really tackle and address some of these things over the coming years in Northamptonshire. And I look forward to working with lots of you and hearing more about your thoughts and feedback about how we take practical action, look at the data, see what we need to do for our population and for our staff, and do something that makes a difference here. The conversation is helpful, but the conversation isn't sufficient. And that's my commitment to all of you in my role going forwards, working with Angela and colleagues. But thank you all so much for joining us today. It's been a tremendous session. I don't know, Anne, if you wanted to add anything finally, or if at that point we're kind of closing things down for people.
Yeah, I think we'll. I mean, I'm almost got no words, because it's been very motivating and inspiring to hear everything. Just a reminder on the screen is, in terms of our NHCP, our commitment to supporting colleagues. So there are 4 different strands of that currently, but this is work in progress. I'm just conscious of time, so I'm not going to go into them in too much detail, but also on here is the contact link for Diana, who you will have heard from today. So again, please connect with Diana, and you will be hearing more from us as we continue this work, as we move through. And then finally, from me, we are using Slido today to capture. We will send the link out to everybody, as well as sending the slides from both Tuesday's session and today's session, and the recordings of both sessions. So everything will be there for you to use and revisit, because there's a huge amount of data in there, and certainly I want to revisit them when I'm not worried about Teams, breakout rooms and all of that, and just listen to them and absorb them. But if you could fill out the survey, there's only 4 or 5 questions on there, but just thinking about the actions that you personally are going to take to make a difference, that's really important. And finally, a thank you from me to all of you, and wishing you all a very good rest of the day and a lovely weekend when it comes. But thank you all very much.
Thank you.
Thank you. Thanks both.
Thank you very much.